Hello and welcome to our webinar on implementation science and looking to Nigeria's leadership in how to build networks and robust implementation science infrastructure. We'll be getting started in a few minutes, so thank you for your patience. As folks are coming into the room, if you could put in the chat box your name, where you're from, the institution you are representing, if any. We'd love to hear who you are. So please share with us. Please share who you are, where you are, and anything else in the chat. We're going to be getting started in a moment. Thank you for your patience. Hello and welcome to the webinar sponsored by Child Family International. Today we are focusing on implementation science and the nexus of practice and research. I'm super excited to learn about lessons from our Nigerian colleagues, and to help us explore this topic, we have Dr. Eche Eze-Anolue, who is a professor of pediatrics and epidemiology at University of Nigeria. He's the former director of HRSA-funded Nevada Comprehensive Maternal and Child HIV Program. He's director of NISA, which is the Nigerian Implementation Science Alliance. Welcome, Dr. Eche Eze-Anolue, and thank you for your grace with my limited pronunciation. And then we have John Aluepo, who is the Associate Director of the Center for Strategic Integration at IVIN, which is the research institute at the University of Nigeria. He's also an Associate Clinical Professor of Global Health at Northeastern University in Boston. Welcome, Dr. Aluepo.
Thank you.
I just get to be the facilitator and convener today. I'm Dr. Jessica Everett, and I am the Global Medical Director of Child Family Health International. Child Family Health International, or CFHI, has rotations in global health, public health, international medicine in 10 countries for pre-health, health science, and postgraduate trainees. Our motto is let the world change you. And today we get to do that by hearing about how implementation science is being built and improving the health of Nigerians, and providing a role model for countries to follow in network building and infrastructure building. I want to draw your attention to a couple of exciting new CFHI initiatives. We have recently launched a portfolio for resident physicians to do international electives in partnership with CFHI. We also have an exciting program in Durban, South Africa, which is where the highest prevalence of HIV is in South Africa, focusing on community-based health infrastructure for HIV and chronic disease. And as usual, we also have practicums for graduate students in public health and global health. So check out all those opportunities. And without further ado, I would like to welcome our speakers and engage in this exciting conversation.
So, John, do you want me to go over from here?
Yes, please go ahead.
Thank you. Thank you, everyone. Thank you so much for having us share our experience. Uh, Jessica has done an introduction. I'm going to give you a little bit of more background so you can understand where I come from. I went to medical school in Nigeria, and I immigrated to the United States after that. And I did my residency in pediatrics at Howard University, a fellowship in infectious disease at New Jersey Medical School before joining the faculty at University of Nigeria, where I did my usual thing and until I was a tenured full professor at the university. Then I was asked by the president of Nigeria to come back to Nigeria to help with the primary healthcare system. The Nigerian primary healthcare system is made up of almost 750 hospitals across the country. It's the largest health system in Africa. And my role was to improve the primary healthcare system. I stayed a little while there and then came back to the US, but decided I think after 25 years, it was time to go back to Nigeria and do something to contribute. So that's how I went back to start the building on what I've been doing over time, the Nigerian Implementation Science Alliance, and then developing the Ivan Research Institute with a couple of my colleagues, including John Olawepo, who is going to speak more to this. But I want to give you this background about the Nigerian Implementation Science, and so you can understand what we met when we started. So PEPFAR came to Nigeria. The Present Emergency Fund was created by the US president, and most of you know, in 2003, and opened their first time in Africa. The two countries was Senegal and Nigeria in 2004. That's where the program started, their first work. So in Nigeria for 10 years, it was run by US institutions. So you see the Harvard University, University of Maryland, Columbia University. These were US institutions that built very great infrastructure in Nigeria. As of the time it was coming to 2010, I was a Robert Wood Johnson Health Policy Fellow at the Office of the Secretary for Health, Kathleen Sebelius. And the agenda at the time for the US was to begin to transition from US institutions to Nigerian-led organization. So you see those transition. Harvard University was transitioned to a local organization called APIN Public Health Initiative and led by Nigerian. University of Maryland was transitioned to IHVN, Institute of Human Biology, Nigeria. They had Institute of Human Biology, University of Maryland, and now Institute of Human Biology, Nigeria. Columbia University transitioned to CIHB. So you see this transitioning happening around 2012. Around 2012, something else happened also because PEPFAR was not authorized at the time to do research. They actually took the first bottle of funding and took it to NIH and asked NIH to carve out a call for implementation science. And you will see that as the first call of implementation science from NIH. So this happens to be at the time that because by the time I was in the Secretary's office in 2010, every day programs were coming up and Nigeria was being in the front. So in the meetings, it will come up that there are 22 countries that account to 90% of the HIV, 21 of them in Africa, one is India. Out of those 22 countries, only 4 countries where HIV testing was less than 20%, and that was Nigeria. So the secretary will turn to me and say, Echa, are you not from Nigeria? I put my hands above my head, and he said, well, why don't you go and do something? I say, I don't know what I'm supposed to do. Harvard is there, Maryland is there, Columbia is there. If you look for smart people, you have it. So, but something she said that made me started to move to work in Nigeria at the time. Most of my work was in the US, in Las Vegas, where I live. I was an ID doctor and I was doing clinical trials. So HPV vaccine, rotavirus vaccine, that was my thing at the time until I went to her office. So she said, I think it's something. We are spending 4 billion, so much money in Nigeria. I don't understand why we can get only 20% testing. So she said, if you could look at it, I said, okay, I'll look at it. But actually, when I started to look at it, that was my transition to that in Nigeria, was actually to see what the problem was. A lot of the things were designed in the same way in the US, all health facility. But the problem is that only about 30% of Nigerians deliver in the hospital at that time. If you captured every woman that came to the hospital, 100%, you'll be capturing 30% of pregnant women. So you can see where the problems are. So at this time was also when I got my first R01 to work in Nigeria. And this was to actually work in the church to show that you can take HIV testing outside of the hospitals and be able to look at community-based testing. So that was one of my first. Now, it was actually a baby shower, and John will talk about it a little bit more, that was funded by NICHD and NIMH. But this considered to the time that I came in was when this transition was happening. And there was a need for leadership at that particular point. And it happens to be being a place in the right time and the right place and having the idea. So I asked almost all of the organizations that was being transitioned from the US to Nigerian leadership, why don't we come together to really do something? So this involved local implementing partners, academic institutions, policy institutions, the federal government of Nigeria, the state government, the local government. Next slide, John. And then we said two things to really be able to do. Our main goal at the start was to evaluate, to generate, and to disseminate implementation science evidence that improve outcome for disease of public health importance in Nigeria. We created three main specific, one step back. Three main specific objective. One was to create a dissemination platform that brings together policymakers, implementing partners, researchers, and program implementers. The second one is to increase the capacity of implementation science. Nigeria has a well-educated trained force. What we wanted to do was to go into that educated trained force to see if we can build capacity for implementation science and research. And the third thing was to build a research infrastructure to conduct clinical trials and implementation science. I'm going to hand it over to Dr. Olawepo to really take us on how we have been able to do these three main objectives. This is our 10th year. We are celebrating our 10th year. So if you are looking for a nice conference to actually see what is going on, this is one conference to be at. And one thing that we pride ourselves is that when we started, we said we are not going to take external funding. So we did not take funding from USAID, from CDC, from any other person to actually build this because we wanted it to be sustainable. And I think we were looking 10 years ahead at this time when the global health is changing. But this year, our conference is going on because it really has never depended on what is going on around. It was all of us coming together to find these common purposes. Over to you, Dr. Olawepo, please.
Okay. Hi. All right. Thank you. Thank you, Professor Zanoli. So I will just continue from there and to lay the ground on implementation science and some of the things we are trying to talk about. I mean, some of you may be very familiar with this infographic that talks about how long it takes for research to become practice. And the whole essence of implementation science is to say, how do we close this gap? What can we do in terms of whether we are practitioners, clinicians, or we are other kind of cadres of healthcare workers, or we work in the community, or we are purely research scientists? What can we do, right, to close that gap? So people have defined implementation science in multiple ways, right? But one of the commonest definitions is that it is a scientific study of methods to promote systematic uptake of research findings. And that systematic uptake of research findings is important because that's the only way it gets to the clinician by the bedside or the nurse or whoever it is that needs to use that knowledge, right? Someone also talks about how do we translate research findings into routine common practice, closing that no-do gap, right? There are a lot of stuff that we know, but the important thing is how have we put it into action? How have we used it to address the problems? And one of the examples I'll talk about, so you see, I think the commonest example I usually use is something like cervical cancer. Why should we still be having women dying of cervical cancer? We know how to prevent cervical cancer, but yet women are still getting cervical cancer and women are still dying of cervical cancer. You know, that's something that we really can't prevent in totality. So as a background, for those of us that are not very familiar with Nigeria, Nigeria is located in the heart of Africa. That's how we like to describe it, and is divided into 6 geopolitical regions, and you see them colored separately. What you have there as dots are some of the sites where we work. So we work across 36 sites across the country, and you see they are evenly distributed. We have 2 secondary and primary level clinics in each region. We have 2 tertiary hospitals in each region, and we have 2 community-based sites in each region. So that makes it 36. All right, so I'll use 3 examples to talk about some of the work that we've done and the results that we've produced. If we could play this video very shortly just to show people, and I'll talk through the video. The Healthy Beginning Initiative, right, which is the community project that Dr. Ezanole was talking about, is very critical to everything that we do. It brings into cognizance the role that communities can play, right, in terms of helping to address diseases of public health importance. We've used, okay, and if it doesn't play, it's fine. You can just post it in the chat and we can continue the discussion. Essentially, what we do is that community-based approach is split into 3. When we've used it in churches or places of worship, right, it starts with a prayer session, right? And after that, we do a baby shower where we gather all the pregnant women together and they celebrate the pregnancy. Then the third part is what we call the baby reception, where when the women have their babies 6 weeks after, we gather them together and we celebrate the babies. Essentially, what we've been able to use this project for, if you could go back to the slides, please. Essentially, what we've been able to use this program for is that we've been able to use it to screen for diseases of public health importance. Diseases like malaria, hypertension, sickle cell disease. So I'll just show you some publications of what we did, right? So this was when we used it to screen for HIV. Now, one of the things, apart from screening pregnant women for HIV, we also use it to address and attract male partners of the pregnant women. This was a huge achievement because this was something we were already struggling with across most parts of Africa and even low and middle income countries. Men don't come to the hospitals, they don't come to test, they don't come to screen. So this program, we were able to use it to leverage, and we got over, was it 60 to 80% of male partners of the pregnant women that came for screening for HIV. So it was a huge achievement, and PEPFAR adopted this. Another thing we've done is to use it to screen for hypertension. In the communities where we work, and in many parts across Africa, people have very high blood pressure and they still walk around not knowing that they have high blood pressure. The example I usually like to give is like, we're a soccer-loving country. So when people are playing soccer and someone plays and it's a goal, you see someone just drop dead due to cardiac arrest. Or someone is making so much noise or getting agitated from a soccer game because of their high blood pressure that is undiagnosed and untreated. You just hear so many cases of cardiovascular events, right? And one of the things we did here was to use this study, this community approach, to identify people that are living with undiagnosed hypertension and then to link them to care. Another thing we've done is also to use it to screen for hepatitis B, something that is very common, that is usually undiagnosed and untreated in many low and middle income countries. We've also used it to screen for mental health issues, especially issues around perinatal depression. We've also used this platform to screen for sickle cell disease, right, in the communities, especially knowing that this status doesn't change. If we're able to identify the mother very early or the young girl very early, as they make their decisions for marriage and cohabitation, they know who to partner up with, and it can help to address the transmission of sickle cell disease. We've also used this for multiple other diseases, but okay, slide is not moving forward. Okay, that is about the baby shower or I'm sorry, I don't know the slide. Okay, the baby shower or the community platform. we've used it for multiple diseases. Another example I wanted to give is what we call the ACCESS study. This ACCESS study is for cervical cancer screening. Like we know, cervical cancer is prevalent in many low and middle income countries, and is something that we can easily address. We're able to use the HPV vaccine and give it to young girls very early. And we also screen young women that are sexually active for either using pap smear or visual inspection or whichever HPV DNA, whichever screening. If we combine those two strategies, we know that we can virtually eliminate cancer. However, this is not knowledge that is esoteric. It's something we know, but we still do not do it. The question is always why? Why? Sometimes it's purely political will, sometimes it's resources, sometimes it's other things. So one of the things we've done is to take all of that knowledge, and we wrote a grant in collaboration with some of our partners from UC San Diego, University of California, San Diego, a 5-year study, and we're in the 3rd year of that study now. And one of the things we are doing is we recruited over 4,000 women that are living with HIV. And we've developed some strategies that we use both in the hospital and in the community to encourage them to get screening. And when they get screened, to make sure that they get treatment immediately through cryotherapy, right? Or ablative treatment. And the success of that screening strategy is evident, and we are hoping that we'll be able to publish that hopefully by the time we finish collecting our primary endline data at the end of this month. But to do that, we've also used multiple different kinds of implementation approaches. One of the frameworks we often usually like to use is the EPIS that was developed by Gregory Aarons from UC University of California in San Diego, and is one of the multiple principal investigators on this grant. That's the ACCESS study. Okay, a third example I want to give is another study, NIH funded, that we call the Community Vital Signs. And here we are using that platform I talked about at the beginning, the baby shower or the Healthy Beginning Initiative, to screen for undiagnosed hypertension. So what we did before was a pilot study. Now we have a full grant to say, how do this community approach to screen people for cardiovascular events, especially hypertension, and then link them up to care. So essentially what we are testing is that we do the screening for everyone. We pull the groups into 2 groups, and one group, we give them a mHealth card, we give them medication vouchers, and we give them facilitated linkage to care with text message support. And the other group, we give them just mHealth card and medication voucher. And we want to compare those strategies in terms of evaluating which of them works or which of them works better, to make sure that we can screen these people, identify the undiagnosed hypertension, and link them up to treatment. So that's what we are working on. For this study, we are going to screen 24,000 people, 24,000 adults across Nigeria. All of those 36 sites you saw, we are going to screen 24,000 people. And we think that will be one of the largest community-based studies in terms of the population of people we are going to screen. We have. And we are hoping that we will learn a lot of lessons that we can share with many low and middle income countries, and that can also serve for what we now call reverse innovation. Those lessons that we learn from there, the question is always, how does it benefit the American taxpayer? What can we learn in those settings that we can use here in the US, especially in some of the rural areas where they don't have as much access to healthcare providers and access to even the technology that they need. So those are some of the things that we are working on at this time. Next slide. Okay, so those are 3 very broad examples. One on cardiovascular disease, one on the Healthy Beginning Initiative, and one on cervical cancer among women living with HIV. But just to talk about NISA now as a whole, what do we have to offer? This is what our infrastructure looks like. At the center is NISA, the Nigerian Implementation Science Alliance, Then the Ivan Research Institute is like the research coordinating center for NISA. Now, we have a lot of collaboration with government partners and policy implementers, right? And here we work with agencies that are dealing with HIV, cancer, mental health, cardiovascular disease, palliative care, sickle cell disease, and many other diseases. We also have global collaborators that we write grants with and submit grants with and get grants with. One of them is the University of California, San Diego, Northeastern University, where I also work. We have with Oregon Health and Science University, our CVS grant is in collaboration with them. We've done research projects, grants with Johns Hopkins, Duke, University of North Texas, and many others. Our key infrastructure are the 36 sites, and that's what you see at the very top. And there, what we've tried to do is to build health facility and community dyads, so that whenever we do work in the community, there is a health facility nearby where we can refer patients to, or we can refer those that need any kind of health services to. And those health services also work closely with the communities. We actually engage what we call a community research engagement officer. This person does a lot of health education in the communities and linkages between the hospital and the communities, right? So this is our infrastructure. So for those that are interested in doing some work in Nigeria, we have the health facility resources, we have the community resources, we have the policy resources, we have the laboratory resources. So at the center there, we have a highly innovative that can run samples, any kind of samples that you are working with or that you are doing research with. So next slide, please. What else do we have? We have, historically, from NISA and the work we've done, we have recruited about 10,000 women of reproductive age that are living with HIV. So that's a cohort. We just published that paper in March this year. So for those that are interested in doing research among women of reproductive age group, this is a cohort that is in existence. Currently now, we are recruiting a matched cohort of women that are HIV negative, so that we can match HIV positive women and HIV, or women living with HIV and women living without HIV, so that we can measure multiple outcomes in terms of the differences between those two groups. We can look at chronic disease like hypertension, diabetes, and all the other stuff that we want to look at, and even their reproductive health outcomes. We have the 10,000 women living with HIV. Now we are currently at about 5,000 women living without HIV. So we are hoping that we can complete that cohort before the end of September. Okay, what other opportunities exist? At NISA and at Ivan, we have conference rooms, we have an office building, and we have guest houses. Why do we say this? In case there are students either affiliated with CFHI or that on the chart that are interested in doing short-term electives or even long-term electives, and we are talking about anything as short as 1 week to 6 months to a year, we have the resources to host those kind of students, right? So we have a building in the university, right, where we have our office. Then down there on the bottom right is the guest house. This is a 6-bedroom, fully suited guest house. So it's based in Enugu, Nigeria. We also have affiliations with guest houses in Abuja, in case anyone is interested in staying in Abuja or staying in Enugu. So there are those resources. So whether both for faculty or for students, right, that are interested in doing short-term electives, internships, or other kinds of affiliated activities, we are highly interested in hosting you if you are interested. Next slide, please. All right. Another of our capacity building platform, we have multiple of them, is like a weekly research in progress. Here, for the past, we started this during COVID. During COVID, for like 52 weeks of the 50 weeks of the 52 weeks, we held a 3-hour weekly research in progress meeting, and we do it every Monday. right? Why is that good? So this is an opportunity for people that have research ideas, especially focused on implementation science or even other kinds of research ideas. They get an opportunity to share those ideas. Other scientists listen to it and they give feedback. So it's like a place where you can come and let people give you feedback free of charge. And it's been very successful. Using this, we've been able to submit so many grants. Nearly 50 grants in 2 years or 3 years. We didn't get everything, but we are making progress. Another of our capacity building platform is the monthly webinars. Once a month, on the first Monday of every month, we have our monthly webinars where we invite people that have done work in implementation science, like Gregory Aarons. We invite people from the NIH. We invite people from USAID, CDC, WHO to come talk to our participants. Then we have our biannual implementation science workshop. This is what we call the NISA Research Week. And you see the flyer on the right-hand side is an example of the NISA Research Week from this year. So we bring people from all over the world to come talk, and we pair them with someone that has used maybe that framework, that implementation science approach within Nigeria, that will pair them together, and someone describes the theory, but someone describes the actual implementation. So it's like talking about the EPIS framework or the CIFAR framework. Someone would describe, whoever developed it will talk about the CIFAR framework and how they developed. But someone that has used it in Nigeria or in Africa will now tell us, okay, this is how I used it. And these are the challenges I found when I used it, Then we have our research grant management training. The Ivan Research Institute and the University of Nigeria is one of the few universities that have received a G11 grant, which is mostly focused on research administration. It's one thing to get a grant, it's a different thing to actually implement the grant per protocol. It's also a different thing to implement the grant and be fiscally responsible, making sure that the resources are used wisely, which is some of the challenges we face in Africa. Sometimes it's not due to corruption, it's just people don't know how to use, or people don't know how to work within the framework of US government-funded grants. So it becomes really very difficult. At University of Nigeria and the Ivan Research, we can train people on how to do that because we have a G11 grant that has trained our staff. Then we have the annual NISA conference. This year's conference we hold in about 3 weeks from today, from September 11 to September 13. So if you are anywhere around Nigeria or you are interested, please join us. We've held this conference every year for the past 10 years. The only time we missed was 2021, right in the middle of COVID, right? But otherwise, this is our 10th year anniversary, and we look forward to celebrating it. Then we have the CTES Scholars Program, which is another platform where we get early stage investigators and they come with their ideas and we teach them how to write grants. And after a 12-week didactic lecture, we also do a full-on mentor-mentee meeting for another 12 weeks, making a total of nearly 24 weeks. And the expectation is that at the end, they submit a grant. And many of them have been very successful. So for that program, our mark of success is that they submitted a grant. They may get it, they may not get it, but at least they learn how to actually write a grant. And it's not theoretical, they actually submit the grant. So that's the CTES Scholars Program. Next slide, please. I'm not sure why it's not moving forward. All right, so this is the leadership. One slide back, please. This is the leadership of the Ivan Research Institute, led by Professor Ezanolwe. I also work as one of the associate directors, but in terms of acknowledgement, is also paying respect to these other people and the efforts they've put into building what we have. We have Professor Onyeka, we have Dr. Aronu, we have Dr. Ebemere and Dr. Lakunde. We have what we call the shared faculty vision. All of us here have another appointment. So Professor Onyeka is a professor of anesthesia, for example, at the University of Nigeria. Dr. Aronu is an associate professor in sociology at the University of Nigeria. Dr. Ebemere is an assistant professor of nursing and Global Health at Duke University. Dr. Lakunde is also an assistant professor at University of North Texas. So we all have multiple things that we do, but we've brought all of that together to help to support the growth of this implementation institute right there in Nigeria. Next slide, please. I'm not sure why it's not moving. All right, so in terms of conclusion, and I want to stop here so that we can take a lot more questions. In terms of conclusion is to understand that NISA and the I-Country practice-based research network has come this far because of collaboration, right? And we are talking of collaboration from both the government, the partners that formed NISA, and the people that have put in their time to build it this far. And of course, the patients that have decided or that have agreed to join our studies or our cohorts. And we've come this far, and we hope that we can continue to grow that framework, to grow that infrastructure, not just the Implementation Science Alliance, but also the actual research infrastructure that can support some of the students that CFHI has, some of the residents that CFHI has, and all the other people that are looking to do some work across the continent of Africa. And we hope that some of the things that we do, many of the other LMICs can also learn from it and develop something similar, right? So that the research infrastructure can expand, right? And there are many more opportunities for people to grow, both students within and outside of LMICs. And we hope that some of those lessons can also carry over to high-income countries. There are many opportunities for us to have South-South collaboration and even South-North collaborations, and we look forward to building that out. I'll pause here and see if Dr. Ezanole has any other comments, then we'll open it up for questions. And I think there are many other things we can say when we hear the questions. Thank you.
Thank you, Dr. Loyopu. Thank you, and this is just our. I think this slide is important that he just put up now, and this is to tell you also that this is a concerted effort of so many different groups in Nigeria. Because one of the challenges that we hear a lot of time is that building capacity in Africa, and we want to go a step further, which is to build skills. And somebody asked us, what is the difference between building capacity and building skill? And there is one example that we give. We went to a meeting where we were working on teaching people how to do systematic review. And we say so there were about 200 people attending this conference of public health experts in Nigeria. So we asked all 200 of them to stand up. And we said, if you know how to do systematic review, keep standing. And if you don't know how to do systematic review, sit down. So about 50 people sat down. So 150 people were standing up. So these are people who had a PhD or MD, who have got an A in systematic review course during their training. So they all know how to do systematic review. So they were standing. So we asked the second question. So that's capacity. They have the capacity to do systematic review. We now say to the 150, if you have done systematic review, keep standing. If you have not done systematic review and submitted and published it, sit down. Only 2 people were standing up out of that 200. That scale, that is a different thing. So all that we do is we really want people to, we are taking the people other people have built. So that's an acknowledgement of so much that goes into building somebody. They have built them to the capacity, but then we give them the platform to do the skill. You have gone to Harvard University, you have done your PhD, and you want to saw your hand a little bit, and you say, I want to go to Nigeria. I want to spend 8 weeks with them. I want to go to the 12 sites. I want to stay in one of those sites and put my hand to the ground. And we make sure that their studies are going on. That's why we continue to write grants to make sure the studies are allowable to mentioning, so that it's there. So we design something for you, and that's why we like when CFHI asks us to do this, they do an excellent work already. So we want to be a place that you could choose to go to through CFHI and said, I want to go to Nigeria, and we will work with them and be able to plan out what you do. And these are the members of the Nigerian Implementation Science, and there are 20 of them. These core people that you see here, of course, that will help in any of their sites. You could actually spend time. So he showed you, we have places in Abuja and in Enugu. So we actually have place you can stay. We have a bus, a driver, we have a cook, we have a gardener. So you will stay a good time there. But the most important thing that you have this platform to actually go there and stay with the 12 research coordinators that are collecting data and see actually the challenges of collecting data. So you can actually respect when you are analyzing secondary data and see how much work those people on the ground put into selecting those data. But thank you so much for giving us the opportunity to share what we do. And then hopefully through the question and answer, we can expand more. Thank you all. Back to you, Jesse.
Thank you. Thank you, Dr. Olawepo and Dr. Adriano Lue. I am just so grateful. And there's so many thoughts and questions going through my mind. I would love to see if any of our attendees have questions or comments. Go ahead and put those in the chat box. I guess I wanted to bring up, it seems like through your description that there might be a different ethics or ethos for implementation science. The way you describe the pairing of research infrastructure and clinical delivery systems, that if the research is finding, undiagnosed hypertension or other health conditions, that the ethics of implementation science is a little different than other types of research in that you actually connect people to care. Did I understand that correctly? And how do you see it
Absolutely.
as a unique research ethos and ethics?
I will take this one, Dr. Lavapo, you can add to is that it's to say that it is really we always ask ourselves in design of implementation science. Remember, in implementation science, we are not looking for new interventions. We are looking for evidence-based interventions, something that has proven to work. Something like, say, aspirin will prevent second heart attack among people who have a first attack. And only 20% of people who have a first heart attack are getting aspirin. Why not? You say that hydroxyurea can reduce stroke among individuals who have sickle cell, but only 30% of those who have sickle cell are on hydroxyurea. Why not? Hypertension can be shown as a heavy risk factor for stroke, and stroke is one of the disabling disease in LMICs because it condemns the person that now no longer can walk, but then the family members that have to now take care of this person. So it is there, but you can prevent all of that by hypertension. Why are 27% of the population walking around not knowing that they're hypertensive? So when we try to design anything, we always ask ourselves in the question, so what? So you're not identifying people with HIV, so what? So you can publish a paper or get a grant. No, it's so that you can link them to a care and prevent mother-to-child transmission. You are looking at those people who have undiagnosed hypertension. So what? So that you can link them to care, treat the hypertension, and reduce incidence of stroke. So our continuum on implementation science is what already knows how to work. If you're trying to test something that has not been proven to work, we have the infrastructure. That's why we can also do clinical trial. But that is not implementation science, unless it has been proven to work. And you are trying to look at why is it not working, not because you're trying to say, does it work? So again, in clinical designs, you have the hybrid implementation studies 1, 2, and 3, and we can talk about it. But you can now bring both of them together, where you're looking at clinical effectiveness at the same time you're looking at implementation outcome. And those are hybrid designs that you can also use to answer the two questions. But you're right, we don't do studies that identify people and then stop there. We always end with outcome, linkage to care, retention in care, effective treatment, and better outcomes. Thank you.
Thank you.
There is
And
actually a
yeah,
question that someone put it in. I'm so sorry if I do not say the name accurately, but Dolapo. They said, thank you for this, sir. Please, do you have a framework for doctoral students who want to conduct dissertation research in your facility?
Dr. Laup, I'd like to go and if I have anything to add.
Yeah, absolutely. So Dolakwa, thank you for the question. Absolutely. So we have framework for anyone along the academic ladder. So we've had interns that are undergrads. In fact, we've had interns that are high school students,
High school,
both
yep.
from the US and from Nigeria. We've had undergrad students that are in Nigeria and are in the US join us. We've had postdocs we've had PhD students. So currently we have data that we are generating on the cervical cancer and HIV grant for over 4,600 women of reproductive age. We have data that we have for 10,000 women living with HIV. Now we are collecting data for another 10,000 women without HIV. So whichever kind of question that you want to answer for your doctoral dissertation, if you think you want to do it in Nigeria, and by the name Dolapo, I'm assuming you are Nigeria or affiliated with Nigeria, because that's a distinctly Nigerian name. We are willing and able to partner with you to show you, okay, these are the kind of data we have, and have that discussion around what kind of research questions do you want to answer, right? And if it is access to secondary data, we can do that through the framework. All you have to do is fill in our form, and we can have a discussion internally, invite you to the meeting, have a discussion with you. Then after that, if it works out for you and for us, then we can now give you access to the data after all the ethical approval has been done. But that is easy, because what we do uniquely that is different to our group is that we have a single national IRB. So all those 36 hospitals, any kind, 36 sites, any kind of research we want to do there, we get just one single IRB approval from the national body. And once we do that, all we do is just now submit that to any of the hospitals where we work. And we've done this for multiple grants, and they are all okay with it. So the IRB process is just one from Nigeria, then of course through your university, if you are based in the US. But yes, there are frameworks to work with you as a doctoral student. But if you want to collect primary data, that also can be done, right? We have 12 site research coordinators in the 12 secondary primary sites, and we have 12 community research engagement officers in the communities, right? So that's 24 staff that are out in the field that can collect data very quickly. So yes, we have the infrastructure to support your doctoral dissertation.
And I just wanted to add to that, and it said that if you wanted to even design something new, for example, we have a 5-year grant from NHBLI on the hypertension study. We are going to be screening 24,000 people for hypertension. Assuming you have an idea, you wanted, remember, Dr. Love talked about this will be done by these 24 highly trained study coordinators out in the field that have done multiple studies before, and you have an idea, and you said, okay, since you are going to be addressing these people, I'm interested. Dr. Loipo was interested one day. He woke up and he wanted to think about sleep apnea. And he said, can I really have a sense of all of these people about, we will add that. And then you design the questions, we will include it in the IRB process, get it done, and then you can assess incidence or prevalence of sleep apnea among this group. That's one of the projects that he's doing there. So you can come up with your own idea, knowing the infrastructure, and then use that for your PhD if you want to do primary or your master's, or even if you're a faculty member trying to generate pilot studies for a grant. So there is that infrastructure is really what we spend our energy building. The way we describe it as a team is that what we are building is a Christmas tree, and people can hang ornaments on it. And the truth, if you ask us to hang our ornaments, they will all be black. But we want it to be a pretty, so we want you to hang yellow ornament, green ornament. So whatever your interest is, what we are really going to provide you is infrastructure in terms of infrastructure in hospital site and this, but also the human capital in terms of research coordinators and community research engagement officers that will actually help you in recruitment, will actually help you in data collection in a very well. And we have a very clear IRB. We, all of us, support our national IRB. The chair of the national IRB, Dr. Debola, is a fantastic guy. He was a researcher like all of us who later went into government. His main goal, he's like me. He said, I'm done all I want to do. I want something new. And his goal is to improve the IRB process. I mean, this last month, the RB process went online for the first time so that applications can go online. And we met with him last week, and we plan to meet with him every quarter. Our faculty member volunteer to review protocols. We don't, of course, review our own protocol, but we want to make sure that so that the timeline to people who submit articles are lower. So there is a huge work he's doing there, and we're very supportive of that. Thank you.
Thank you so much. Lots of good questions coming in. I wanted to go back to something that Dr. Ezenalowe said, which was around how you intentionally set up the organization to have a prioritization of sustainability over, I think, a large influx of cash from like a US-based institution. I wanted to get your opinions on what are some of the biggest mistakes that you see outsiders make, particularly those from the US or Western frameworks when working in Nigeria? What are some of the ways that colonialism or other ways of thinking shows up that makes people less successful? And how can outsiders be more successful?
So I will respond, and Dr. Loipo, you can add to it. And it depends on how you define success. So I want to start with how I define success. So if he agrees with you, then you can see my explanation. I believe that success is what happens after you have left, not while you are there. So if you are the university president and everything is going there because you have power, you control everybody, and everything is going on there, that's great and fine. But I don't think we should judge you based on that. We will judge you when you leave as president, and we see what you left behind. How many of them succeeded after you? So why is that important? If you define success that way, then you see how we think some of the challenges are. People think about sustainment at the end of their grant. They come in to do a project, 5-year grant. Nobody talks about, but they say, oh, we want to transition to the local, but you only talk about the local people after you want to present your result. So they were never engaged. You should have sustainment as part of your study from beginning. So when you talk about actor engagement, stakeholder engagement, you should think about engaging the people who will continue that project if it's found to be effective. So sustainment and sustainability of projects beyond funding project time should be there, not your 5-year and in the 6 months of the 5-year you say I'm doing that. That's one of the biggest mistakes that we do. So we think that's one of the reasons we actually exist. We say we will be your partner to be able to do those things. So that when it's done, this continues to go on because we're already engaged. This is what we love to do. This is what we do. So as part of that, so that's one of the mistakes that we see a lot of time is to think of sustainability as an afterthought. The second thing that we think is that people think you have to get a D43 or a training grant to build capacity among the people you work with. I don't think so. If you got a 5-year grant, you have a moral responsibility to build capacity because that's part of your sustainability plan. Because if you don't build the capacity of the people, how are they going to take over from what you're doing if you never build that capacity? So these are some of the challenges we see. When I don't have a T43, I'm going to do my research and go. Your interest is, that's what we call those people who fly in and then fly out. But we don't want this. We want you to come in and say, I'm going to build the factory. I'm going to do this study. But by 5 years of my doing this study, one thing, whether NIH funded you for it, whether whoever funds you fund you for it, you should demonstrate that you build the capacity of the people that you work with, because that is part of your sustainability plan. Dr. Laip, I don't know if you have something to add to that.
Yeah, I think you've covered. I think the major thing I'll add is the role of patience. I think sometimes that's why when you get money from donors or funders, they are so much in a hurry for success, whichever way they define it. Sometimes it can be achieving a target, screening this number of people, something. The NISA is celebrating 10 years today, but it took a long time to build what we have now, right? The research infrastructure, it took a long time. If we had received money from the very beginning, most likely that vision may have been derailed because someone would be in so much of a hurry to say there are no results, so we'll cut off your funding. So to answer one of the questions I see on the chat, a lot of the stuff you see that has developed is from seed funding from Professor Ezenalowe and also from the other members of NISA in terms of some of the support that they give, in terms of providing employment or paying staff to do some of the research work for the pilot studies. Also, it comes from many of the people that have been working on the infrastructure, giving their time pro bono, right? Not charging for that time. If not for that, it would have been very difficult. So, for example, one of the things we do at NISA is to say each of the committee, we have 6 committees, different of each of those committees, each of the partners bring or 1 or 2 people and say, okay, I will work on this committee, I will work on this committee, I will work on this committee. We also rotate the hosts of each of the annual conferences. So that has shifted responsibility around and giving people a sense of ownership. So we've not relied a lot on external funding. Yes, if we get external funding for research grants, absolutely, you need good money to be able to do good research. But in terms of building the infrastructure, we've made sure that it has been locally driven, locally owned, and locally funded.
Yeah,
If
I
we
just
had
want to add
relied on
something.
anybody, based on what is happening now, I'm not sure we would have survived.
Yeah, I want to add something that we're doing newly that is interesting. When Dr. Laipo showed you the leadership, we most of us have spent spent individual money because we are committed to this idea. But there's something new. We have an organization that likes what we're doing and actually promise that they will establish an endowment on each of us that is actually working on those things, and they challenged us that they will give they will match each done. So there are 5 core team member that we have, and they were trying to say if you bring $50,000, we will match that $50,000. And what are we trying to set up? We're actually trying to set up a postdoc program. So you will have something like a postdoc program that is set up on the cardiovascular research, which Dr. Olawepo oversees, and said we will have a 1 postdoc, and that's $100,000 endowment, and that actually puts down money that we know that we'll have a postdoc in that position. And that's our sustainability plan that we just launched, and we are doing that. So if you ever want to put a line in and join that, that's one way you can do it. That way we know that there is a postdoc position in cardiovascular disease, in cancer control and prevention, in maternal and child health, in blood and lung diseases. So we actually lay out those kind of things. And if you think what we're doing in terms of general outcome, do that. What we are hoping for is that people from anywhere can actually come in and use this infrastructure. And that's why we spend a lot of the things you see in terms of the building, in terms of all of those infrastructure, so that if you actually come in there as someone who wanted to spend time to 6 months, you want to write a KO1 to spend 50%, you want to come as a Fulbright scholar, that's another thing. We will be your host, and then you can actually provide those kinds. So there are so many ways you can engage and with us, and we are happy through this, and most of you that are members of the CFHI, and to work together to create something new. If there is a gap that you think we can make things better, and the partnership with us can improve it, we are very open to those.
Thank you. We have a question about whether you have any infrastructure in Cameroon, and I'll expand on that. I'm wondering, what are you seeing in terms of relationships or other sub-Saharan African countries utilizing your model, or how would you like to see that happen?
So before the election of 2024, the National Institute of Health actually they were running a 10-year evaluation of the Nigerian Implementation Science Alliance. They did a 3-year running evaluation of it, and they created 1 second. And then they created the West African Implementation Science Alliance, which was launched at NISA. So that included Cameroon, Ghana, Nigeria, and everything. And then they launched another thing to create 10 different areas in Africa. And all of them, what we do is that we support the growth of those teams to grow the same way NISA did. So that's why we embraced to the African Implementation Science Alliance. And that idea was to say, if you wanted to develop this similar thing that we have in Nigeria, we will share with you, we will be a mentor to you and support you in developing those. And then your organization in Cameroon can become part of the African Implementation Science Alliance. This is what we are hoping for, that at one time that Africa can have its own stability to continue projects, because right now what we see is projects that happen and ends when the research ends. And this has been a very difficult type of thing. So we will support you in terms of that. Whether you are in USID was actually taking us to places. Of course, the USID is gone, but we are willing to do that. So that's the whole idea about sustainability, is that if you want to do this, please let us know. We will tell you, we will share with you some of the challenges we faced. Looking at it 10 years, it looks like it was all fun. No, there was no fun. There are sometimes Dr. Olawepo's wife will come on the phone and say, I'm happy that he spent time with you because I know where he is every day, spending 6 hours of his time. Because we spend so much time Saturdays, Sundays. Remember, like he said, when we started, we all had a different job too. So this was more of a program of passion. So Mondays, we've done the CITES Scholar. Today, we have people from Ethiopia. We have people from all different African countries. All they do is to bring in their research idea to the research in progress, and then they present it, and they have people who have worked in the field refine their project for them. We've done this 2 to 3 hours every Monday for 50 weeks in a year for 5 years. That would tell you the amount of investment. So it is something that we're willing to tell. So we are happy for you to join the 2 to 3 hour program there, where you come in with an idea and you can present it, and then you can get a feedback. We are willing to support you to develop a platform in your country that can bring the same thing we did here, all the partners there, and try not to look for funding. That's what we tell people. Have it a coalition of the willing, because if you build it that way, the sustainability is better. The money can come in to help you up and down, but the stability of the infrastructure, that's what we have. It doesn't matter what happens outside of Nigeria. It doesn't really depend on that. What happens out of Nigeria help us in terms of how big we can get, but we can stay that flat, but the infrastructure will be there because it's not dependent on the up and downs of grants or funding like that. So we can help you to set it down, the lessons we have learned, and then you will be seeing before the end of the year, hopefully you'll be seeing that publication that actually reflects on our 10 years. And then we lay down lessons learned in each of those 3 areas that we focused on. And that you can also look at to see, we actually were documenting challenges and how we overcome them. So I think an important part of that manuscript will be looking at the challenges and what we did, so that as you start, you can actually don't have to make the mistake we made.
Yes. Yeah. It's so nice that your experience can be used to help others work in less bumpy ways. And congratulations on all the amazing work. A couple of follow-on items. Do you have an email that you could put in the chat of where people should email you so that they can attend the Monday sessions or the webinars? And also maybe your website URL. People want to pass on their WhatsApp numbers, so we can send those to you. But if you have a WhatsApp number that folks can reach out at, if you can put it in the chat, and then everyone can get connected.
So I put in 2 emails there. One of them is already there, Dr. Olawepo put in there. That is our central email that is there. You can also copy the second email that is there. I don't know if Dr. Ron is here. I would have given you the WhatsApp number, because we do have a group on the WhatsApp. I don't know. I'm going to send it to you if Dr. Ron is not on that phone and there's nobody that have the phone. They will give you. We have a WhatsApp in that group of that partnership. But if you send an email to this, we will send you information. If you want to join those Mondays, we have Monday webinars. If you want to join them, they're free. We have a research week that we do. This last week, we invited 5 institutes from NIH. It's 2 hours every day. And then they actually talk about implementation science. So we invited NCI, and they spoke on cancer prevention and control implementation science. David Chambers and the group Margarita and the Nita, so all the group they have been to Nigeria, they have been to the NISA conference, so they know us very well. We have NHBLI coming to talk about cardiovascular disease research and implementation science. We have NIMH, mental health, to come in. So those are the kind of infrastructure that we do. So you can join any of those programs. I really think what we're trying to do is to build partnerships so that we don't have to rebuild anything that exists. So for us, for example, if you're working with CFHI and then all we want is to be part of CFHI, we really do want to be that. So we are cutting them. Hopefully, will work. That we can be a site for you. So that if you're part of them and you pick Nigeria as your site, they know that they have a partner in Nigeria. I don't think you have a partner in Nigeria right now. So we are hoping that we'll become one of those down the road. And you can go to CFHI and say, I want to go to Nigeria. And then that way we'll be linked up. So that way we don't have to recreate all the infrastructure they already have. They have it already.
Oh,
So go
thank
through
you.
that and then be able to come down to us. Thank you.
Wonderful. So if you missed it, the email is admin@ivaninstitute.org. Is it ORF?
org.
ORG. Okay. Admin@ivaninstitute.org or ctair@unn.edu.ng. And if you want to get your WhatsApp number to NISA for collaboration, please email them at the ctair@unn.edu.ng or admin@ivaninstitute.org. And there's lots of ways to connect. And I look forward to continue to talk about how we can collaborate more closely from a CFHI lens. So thank you everyone for your time. I'm very appreciative and all the creative energy. Take good care.
Thank you. Thank you for having us,
Thank
Jesse.
you,
Thank you.
everyone. Thank you,
Be
Jess.
well.
Thank you, Maria.
Bye-bye.
Thank you.